So our final talk today is Dr. Naga Chalasani. Dr. Chalasani is the chairman for the Division of Gastroenterology and Hepatology here at Indiana University. He's a master clinician. He's also a very well-funded investigator and a very accomplished mentor of a lot of prolific physicians, including, hopefully, you see me as yours truly. This conference is in large part due to the contributions of Dr. Chalasani in our Division of GI and Hepatology here at Indiana University. So please welcome Dr. Chalasani. Thank you.
Thank you. I think there was a question. Let me get this on. Can you hear me? I think there was a question for Terry. Maybe I can take it. Yeah, you can speak up.
What percentage difference is there between brand and generic in the active ingredient? I've been told it's up to 20% above or below.
I cannot tell you the exact percentages. I can tell you it is not 20%. It is less than what is clinically significant for that blood range on that particular drug. So on some medications, it's insignificant, maybe all the way up to 20%, you're going to get the same result. But on other medications, such as levothyroxine that we were talking about early in the presentation, it has a very narrow range, a clinical range. And so it's not always the same for each medication, but it is within the therapeutic blood range necessary to get the same results for that particular medication. Does that help?
As a follow-up, though, if you're taking a generic that may be above, and you switch to another generic that may be below, it could be significant for that patient.
The FDA has done a lot of studies to make sure that range is within therapeutic range, plus or minus. I cannot tell you that every single person's system here is the same, so a lot of that is individualized, especially if you're a high metabolizer or a low metabolizer, also especially if you take medications that can affect, which are many, many medications, that can affect how much that drug is metabolized. So the general guideline of an FDA approving a generic keeps the therapeutic window, and that includes the above and below within therapeutic range, but there are things that make each of you unique, and the medications that each of you take, that can make a difference on that. I would not, however, look at that as a primary reason not to switch generics on most of these. I think those are very secondary to a lot of other things that can affect how well your medication is working.
Can I, maybe I could follow up though? This is really important, especially as the costs of brand and out-of-pocket expenses, et cetera. My approach has been stick with the same thing as long as you can, but you know, the financial situation demands sometimes you go to generic, et cetera. I think having a healthy degree of skepticism, as you're pointing out, is good, because generics come from, you know, I agree with you, but generics come from a lot of different countries. And FDA does really exceptional job, but still doesn't have the resources. I mean, there are 500 factories in China that are doing generic. There's just no way that FDA can monitor the quality. So I think keeping an eye as you are. Another thing, so a couple other points though is, generally speaking, if a patient has had really bad case of autoimmune hepatitis, and if it's been a struggle for me to get them in a remission, I've been very reluctant to allow generic. And I fight with the insurance company to say the same brand should be. But if it is not it's not been such a difficult case, and I think you can try the generic, as long as you, at least first 2-3 months, keeping an eye on with enzymes, liver tests, or so on and so forth, it's manageable. Also, changing from one generic to another generic is a little tricky. And I think that's also at least staying with the same generic. You know, for example, I take a statin, and I think recently my insurer said go to generic, and I'm okay, I'm doing it. But you know, I was scratching my head too, is this going to work as well? So I think these are real concerns. To my talk now, I want to thank Dr. Lammert and his team. Really have done a fabulous job. You probably haven't, some of you know, this really took months and months of planning. every week he and his team met on a weekly basis, planning, goodie bags and registration, getting the institutional approval, the whole thing. Really great job, Craig. Round of applause. And a lot of staff are here. They really have no business of being here on a weekend day, but I think they just really are committed. And Nina here, and I have Josh, Megan, and Gina, and Bobby is one of the residents, and really this is extraordinary. Also, some of the doctors you have heard, Terry, these are stalwarts. Dr. Jacobs, if you call up the clinic and say, I want to see want an appointment with Dr. Jacobs, I think it takes about 6 to 8 months to get an appointment with Dr. Jacobs. Really, really precious doctors. And coming here and sharing I'm truly amazed at their commitment to that. So I'm taking some notes. I'm just going to, before I go to my cases, Dr. Lammert gave me 3 cases to discuss. But I think I'm just going to take my chairman's privilege and keep talking. So the first thing, though, is the diagnosis of autoimmune. It comes on both sides. Some are obviously missed. I suspect many in the audience have had long time before it was pinned down. That happens. Just about every patient that we see has had several trips to other doctors, and it just hasn't quite pinned down. But the other way around is also quite possible. As Dr. Jacobs had said, autoantibodies, the ANA, if you look at the healthy sort of the blood bank donors, you check for this ANA, up to 5% just have these autoantibodies, ANA test. So you will see some physicians, not on purpose, but they just equate elevated liver enzymes and an ANA positive equal to autoimmune hepatitis. That is, so I think, though, at least when I have medical students or residents in my clinic, I always tell them, even if they've been on steroids for months or years, I go back to the original diagnosis, make sure this diagnosis is right, because this is lifelong. You're going to have flares, and you're committing to some serious treatments here. So I think you all should question the provider who's making the diagnosis. How certain are you? Is it just based on my enzymes are high and a little bit of ANA positive, or how certain are you? So that's one. Not everybody needs a biopsy. Some autoimmune cases are straightforward, especially if there is other things like the immunoglobulin levels are high, and I think it's straightforward. And that's one point I want to make. Number 2, though, is there been discussion about alcohol use? Craig?
We very briefly looked at alcohol use in at least a multivariate model, but that's the only science we provided.
And the value of alcohol to human health is sort of going up and down. We know heavy drinking is not good, but a little bit of alcohol seems to have benefits. The trick is, where do you stop with a little bit? And what's a little bit to me is so different than what's a little bit to my wife. And I think that's a point of contention at our house almost on a daily basis. So what I tell, though, is, but at the same time, though, the alcohol has ceremonial value in our lives. When your child is graduating, you should be able to toast, or when you're getting married, you should be able to toast. And I think, generally speaking, a ceremonial glass of wine, once a month, if you can stay within that limit, I think is perfectly safe. It's not a poison by any means. The bad thing is, if you go beyond the ceremonial into regular use, I think is where the problem is. Keep in mind. One thing we have not really studied, that's something we should study, is the combined effect of autoimmune liver disease on the body weight. We have learned in other diseases, for example, hepatitis C, maybe in heavy alcohol users, excess body weight seems to add to the damage. And so that's something is particularly interesting because of steroids add weight. So what is the long-term effect you're controlling, but what is the downside sort of stuff? That's something we probably have to figure out. And I saw some of you taking photographs, and I think it's the plan to put them on available to everybody, the slides?
As we discussed, the slides will be available as well as the audio recording of all this as well. So hopefully in the next few weeks, it'll be up.
And then also any questions, I think Dr. Lambert will leave his cell phone number so you can call him, text.
Please.
And his Facebook. And I think
Let's stick with Facebook and Twitter. That'd be good.
All right. So is there a panel afterwards, or we just take Q&A? Is that the plan? Q&A. Okay. How much time do I have? 15, 20. So I have about 3 cases actually he put together, so I'm going to walk you through. I think some of you may relate to these cases. So, is there a pointer here? No. Okay. So the objectives are 3 cases I talked about, and some description of clinical decision-making, diagnosis, side effects, and treatment challenges. And I think you have heard a lot of these over the course of the last couple of days. So 45-year-old Caucasian female presented to her doctor with complaints of abdominal pain, nausea, and fatigue for about a month or so. No new medications, no high-risk behavior. And I don't know if it's been touched, but there seems to be some relationship between race and the severity of autoimmune hepatitis. It tends to be more severe. The same way, similar to lupus, African Americans seem to have more severe disease and also more difficult to control, more frequency of relapse. Just keep in mind. So these are the enzymes. This is the old SGOT, which is called AST. This is ALT, which is sort of the liver specific, somewhat. This is total bilirubin. This is the autoantibody. There are 2 normally you get checked. That's been covered, I suppose. AMA and anti-smooth muscle antibody. ANA can be noisy. It can be high and even up to 1 in 360. But anytime you see anti-smooth muscle antibody at this dilution, this 1 in 640 is on the higher side. Now I think you're dealing with something real. And this is immunoglobulin, IgG, is about, normally is 1500. This is 2200. That's also high. This is sometimes we follow as the liver disease improves. This sort of goes down. So are the antibody titers. Okay. This, if I'm looking at this in somebody who is 45, seems like a strong case that this person may have autoimmune hepatitis. Another thing, though, just looking at it, I would describe this as a rather mild case of autoimmune hepatitis, although some in the audience may freak out about enzymes are in hundreds. The key really is not how high the AST and ALT are. You could have 1,000 ALT, and that would not worry me as long as this guy here, total bilirubin, is normal. Okay? And this really should be when you have a flare and patients panic a lot of times, and really what I look is at this total bilirubin. If the bilirubin is normal, that's telling you that the liver is still handling the injury. Okay? So to me, especially this is 96 and 100. This is a couple of times upper limit of normal. I sort of take this as rather a mild case, probably autoimmune. And a liver biopsy was done, and there was, you're seeing what you're expected to see in autoimmune hepatitis. There was no fibrosis. This is another big deal for us, is the amount of scar tissue is really what determines the long-term outcome. Although, 10 years ago, if you had asked me, wouldn't have been as certain about the scar tissue improving. Now we have learned that as the liver disease gets improved, the scar tissue may repair itself. Like really the scars that you make on your skin. As the time goes on, scars disappear unless it is really too deep. So that's hope. Even people have, so our pediatric patients with advanced fibrosis, really cirrhosis, and I picked them up. Now I've treated them for 10, 15 years. When I rebiopsy them, really no scar tissue. Even the cirrhosis is resolved. So no, seriously though, I think that's a new paradigm for all of us. Is when I was in medical school, the notion was if you have cirrhosis, it's done. It's not going back. And I think we have learned for hepatitis C, hepatitis B, other diseases, the scar can repair itself. And clearly I've seen in my own experience the kids, at the age of 5 with touch of cirrhosis, and thankfully the disease has been controlled. And 20 years later when I biopsy them, now mostly they're under control, but they wanted to know, they're going through pregnancies to see what are we dealing with. Remarkable, totally normal liver. So for some of you who have had biopsy showing cirrhosis, there is clearly hope that it can get better. Okay, with effective treatment, the key though is to maintaining the remission. What you don't want is these flares. If you have a continuous remission, I think that's really speaks well for your long-term prognosis. So 30 milligrams of prednisone and 50 milligrams of azathioprine were started. And I probably would have started 20 milligrams considering this was a mild case. And prednisone was tapered over the course of 4 weeks to 10 milligrams. And these are enzymes. AST, let's look at ALT, 104, 86, 76, sort of going in the right direction, not as brisk as you would like. And hemoglobin is okay. What are you seeing? This is the white cell count. You're seeing it to go down. And then also keep in mind IgG, the immunoglobulin at the start was 2200, now it is down to 1689. Means the steroids are doing what they're expected to do. And this is a concern. Now white cell count is low. Something is going on. What is that? Anytime you see something like this, you always worry, is the person having a reaction to azathioprine? Azathioprine, if you accumulate its metabolites in the bloodstream, it can suppress the bone marrow, and it is very reversible. The key is to recognize, you stop it. So, another thing is knowing. I have had some patients, the white cell count goes down, and the next thing that I see is they've been to hematologists or they get in a bone marrow biopsy, just because that piece of knowledge is missing, that they did not connect the dots. So keep in mind, white cell count can go down. It is generally reflects the dose, 50 milligrams, which actually is on the lower side for adults. But for a particular person can be high because azathioprine is metabolized. It really doesn't work by itself. It becomes what's called a 6-mercaptopurine, and it goes through 6-TU, which is inactive, and 6-MMP. So let me just do one more thing. So this is the enzyme, TPMT. We all have it, but it can have a variance in a small proportion of people. You could have this abnormal enzyme. So this enzyme is only functioning at the level of less than 1%, okay? So what could happen is if you're not going this way, you can accumulate this. This can cause bone marrow suppression, okay? We don't routinely check for TPMT genotype. The other diseases, for example, Crohn's disease and ulcerative colitis, doctors, they routinely check TPMT genotype because they use far higher doses. And also keep in mind, if you have this, it just helps us to adjust your dose. Maybe we could start lower. But I have not been consistently testing before I started azathioprine because I tend to start slow and build them up. So this patient's activity was 2, and also you can genotype to see what kind of mutations you have. And normally it should be over 12, and this person's was very low. And really all that you need to know is stop the medication, let the body recover, and it'll be fine. Okay. So the dose was reduced by half. In the following weeks, white cell count remained below 2. And azathioprine was stopped and was switched to Celsep mycophenolate. And another thing you could do actually is to measure the metabolite levels as well, as opposed to the enzyme activity. Many times it's in thousands. That tells you that you're really accumulating type of stuff. Anyone had this reaction in the audience? Yeah. So was it frightening though when the bone marrow counts dropped, or were you?
and I ended up having an 8-hour nosebleed. And I had 5 blood transfusion and was in isolation for a week at Children's Hospital.
That's very odd, though. That degree of toxicity is uncommon. I was going to point out, though, is azathioprine, although we use for liver disease, sometimes can cause liver toxicity very, very, very rarely. And that doesn't seem to be related to TPMT. I wonder in your case, though, there may be an element of liver toxicity from very high metabolite levels that accumulated. But the good news is, just give it time and this all will improve. And then also I'm sort of surprised the platelet count dropping and having nosebleed, that seems pretty dramatic though. Oh. Okay. Yeah, that's sort of, so the medicine is like a normal distribution. You always have extreme reactions sometimes. You just have to be vigilant for those extreme reactions, and I think you're one that had such. So next two more cases. African American, 64-year-old, goes to primary care physician with tea-colored urine. Anytime tea-colored urine with itching means that your bilirubin is high. It's almost like your eyes are turning yellow. Keep in mind. For about 2 weeks, that's too long, has also observed mild fatigue, early satiety, which basically means feeling full with small amounts of food, and headaches, and was in the emergency room near daughter's house about 4 weeks before because of severe burning urination, and was given an antibiotic to take for about a week or so. I think you probably can sense what Dr. Lambert is getting at. He's trying to set the stage to see rarely, very, very rarely, certain medications can trigger autoimmune hepatitis. And then I think all of you, have trying to search to see why is that I have it, and trying to figure out is there a trigger. And I think some of you may be able to, either say I had a bad case of flu, I took XYZ, and I think there are some notorious medications to cause autoimmune trigger. Okay. So the patient had type 2 diabetes, hypertension, and hypercholesterolemia, 2 glasses of wine per week. That's acceptable to me, honestly. Smokes about half a pack of cigarettes. That's not acceptable. No, that's bad. These are the medications: lisinopril for blood pressure, insulin, Crestor is a statin, rosuvastatin, and a low-dose aspirin. All seem pretty appropriate for somebody who's 60 plus and who has diabetes and hypertension. Physical examination, sort of eyes are jaundiced, skin is okay, a little bit of maybe low-grade temperature here, slightly high blood pressure, and somewhat chubby, I would say. Or call them fat, You get written up in your surveys. So abdomen is tender, and the liver and spleen are not terribly enlarged. And these are the enzyme, the blood test. Platelets are okay. These are ALT of 778. That's high. That's respectably high. AST is also high. Generally speaking, though, in liver diseases, ALT always higher than AST. Just keep in mind, And alkaline phosphatase is about 426. For this disease is largely not relevant. Bilirubin is 7.2. Now we're talking. You are dealing with an illness where very high AST and ALT, and also liver is not coping with it. Normal bilirubin should be under 1. Anytime you can see jaundice in the eyes, it's about 3. Okay, that in itself is important to me. And then now somebody has a value of a 7. This is, I suspect, on the severe side of an autoimmune attack. Okay? And this is interesting, though. The autoantibody ANA is very low. I mean, this is not impressive. ASMA is another antibody. I think we just talked about it. That's negative. This is another thing. Anti-LKM antibodies was also negative. And the IgG, which is sort of the immunoglobulin, that sort of is, in lay terms, is the one, the antibody that's doing the attack, is about 2 grams. That's higher, okay? And the liver biopsy was done because I suspect in this case, before committing to high-dose steroids, you want to be sure you're dealing with autoimmune hepatitis, especially these are negative. If this patient had an ANA of 1 in 640, I would argue you may not need a liver biopsy because liver biopsy takes a couple of days to wait for the results. In this case, you want to start the treatment quite promptly because of the jaundice, okay? If there is no jaundice, you can sit for 2-3 days and wait for the biopsy results to come back. Once you have jaundice, I think you really don't want to wait too long. So the biopsy was done, and there was hepatitis, which basically means inflammation. And these are the types of inflammatory cells. And there's a little bit of steatosis, which is fatty liver. Our patient, remember, is a little chubby. So really the story here is there are some medications that can trigger autoimmune hepatitis. This is an area that we are studying. This has been known for a long period of time, that certain medications can cause liver disease that looks like a textbook case of autoimmune hepatitis. There are high-profile lawsuits that kids have been given minocycline for acne and had autoimmune-like hepatitis, never connected the dots, and they were trying to treat the autoimmune hepatitis, not stopping minocycline, ended up with cirrhosis, and eventually, finally connecting the dots. So this is Dr. Bjornsson from Iceland. I think when he was at Mayo as a sabbatical, sort of looked at all the cases of 261 cases. In their experience, about 10% had a possibly induced by medications. So 1 out of 10 autoimmune patients in this room probably may have had a drug sort of precipitate the event. This is, I think, an important thing because they behave differently, though. If your disease is caused by a drug, except for nitrofurantoin, the macrodantin, other things, I think generally you can, even for that, I think in 6 to 8 months' time, you may be able to go back into long-term remission without having to take steroids, et cetera. So that's, I think, is, and then of course you always want to avoid the down medication again. But so the 2 big compounds are nitrofurantoin. This is also macrodantin or macrobid. You all should never take it. Okay, people in this audience with autoimmune hepatitis should never take macrobid for kidney infection. And generally speaking, it's primary care physicians don't use this. This is an old medication. We doctors are fashionable. We like to use the new meds, not the old cheap ones. So, but the urologists use this a lot. So still the urologist, this is favored. That's where some patients get on macrobid for months at a time, especially if you had multiple urinary tract infections. They think a low-dose macrobid can suppress. And there is another study we are doing about the drug toxicity. Macrobid, I think we have seen about 45 cases of serious liver injury from macrobid. And this is a problem. Keep in mind, another rule of thumb for me is patients with liver disease, I rarely prescribe augmentin antibiotic. Okay? So if your prescriber ever gives augmentin for sinusitis, et cetera, ask there is an alternative. There isn't necessarily a connection between these two, but augmentin, of all the things we prescribe, of all the medications, augmentin is by far the most hepatotoxic, meaning it causes more drug toxicity than any other prescribed medication. And so I avoid those. Minocycline is used for acne, mostly in teenagers. So your children, I guess, have a predisposition, so I think you should avoid minocycline. I mean, there is a low dose. Bactrim can be used for acne. It's probably correct. You should probably point that out. If you have family history of autoimmune liver disease, probably minocycline is something you should avoid. And you have autoantibodies, et cetera, though. So this is the point. is unlike other autoimmune hepatitis where you get into remission, you can have a flare again. This one, I think majority of the times you can get them into remission and you can watch, and they tend to stay in remission, especially if it is nitrofurantoin or minocycline. Although these are the big causes, there are a lot of other medications that can do autoimmune hepatitis like picture as well. Very rarely statins, and some of these biologics that you use for like rheumatoid arthritis and inflammatory bowel disease, so on and so forth. So the message though is, really what I want to say is avoid nitrofurantoin, minocycline we talked about. We also talked about the avoiding the augmentin. Other than that though is if you get diagnosed with autoimmune hepatitis, or your friends, you all have had diagnosis, but if there's a new case that you know, is asking them to look into their medication history. And what I do honestly is I actually ask their pharmacists, go to their pharmacist and get the records. Because many times you forget, and some of the patients are on a lot of different medications. They get samples, etc. That's another problem. You know, there are samples, they get the doctor's office, they never record it in the pharmacy records, and that adds another layer of complexity for us. But carefully looking at the medications, what you have taken last 6 months or so. This is another thing though, you could be on a medication for a long period of time, especially statins. You could be on for 5-6 years, then boom, you come up with autoimmune type of hepatitis. We have never quite figured out what is that trigger, what's so changed. So medications, you always have to think about it, and also some infections can precipitate as well. This is called a heat map. I told Dr. Lambert to put it up. We just got it 2 days ago from Dallas. What I want to show you is this is really colorful. Let me walk you through. We are trying to study why these are autoimmune hepatitis cases presenting as caused by medications. Okay, we have about 45 or so of the blood samples. We are studying them. These are all had drug toxicity, but clearly by known compounds, but it looks like autoimmune hepatitis. If I don't give that history, most hepatologists would diagnose with autoimmune hepatitis, okay? And this is the controls, meaning these patients had drug toxicity from medications, but they don't have autoimmune-like picture. And the group here already is autoimmune hepatitis. These are textbook cases of autoimmune hepatitis. We have given them steroids, etc. Here we look at this panel of antibodies. So far, all that you have seen is about 3 antibodies, right? ANA, anti-smooth muscle antibody, maybe anti-LKM, etc. So what we want to study is in this group of drugs precipitating autoimmune hepatitis, we wanted to study, are there specific antibodies that can tell us, is this bad luck, or is this that you have autoimmune hepatitis, it just happened to come at the same time, or is there something unique about this compound, etc. I think what you're seeing is, you see red means a lot of antibodies, and these controls really don't have, these are blood donors, it's all green, means that they don't have antibodies. But though within this group, you can see bands of red, almost looks like autoimmune hepatitis. So I think this 40 cases are caused by 4 different groups of medications. So I think we can probably figure out over the course of next 5-6 years what is sort of happening, and maybe a diagnostic test to say what is drug as opposed to what is sort of de novo, meaning you're prone for it. So what's the spontaneous autoimmune hepatitis? So do I have time for the third?
Maybe 2 minutes or so.
3 minutes?
Just a few minutes, yeah.
All right. I'm your boss, you remember?
Not here.
I just ask you out of courtesy, man. So, 23-year-old Caucasian, primary care doctor, routine exam, and her recent disability insurance assessment, and slightly more fatigued, and it's mostly about fatigue, and seems like elevated liver test has hypothyroidism and ulcerative colitis, and has irritable bowel syndrome with fair bit of diarrhea. And you have white cell count, hemoglobin, and platelets are normal. You're seeing moderately severe liver injury here. ALT is about 450, that is about 10 times normal. And bilirubin is slightly high. Normally, is about 0.8, 0.9. You have 1.1 is slightly high. So you're looking at something, moderate injury is going on to the liver. And your hepatitis A, B, C are negative. You have a low positive ANA. ASMA is high, 1 in 320 dilutions. And IgG, again, once again, is high. Not too impressive, but nonetheless, it is high. And liver biopsy was done. It is consistent with autoimmune hepatitis, moderate to severe inflammation. Fibrosis unable to be assessed. And was started on 30 milligrams of prednisone and 50 of azathioprine. Seems like Dr. Lammert likes 30. So what you're seeing here is enzymes are not improving. At about 3 months. Now, he's waited 3 months. On that dose, still they're about 440. That's about 10 times. Started 10 times, still 10 times. IgG is also not budging. This is problematic, though, is sort of in 3 months, our autoimmune hepatitis, if you don't put it under control, you can pick up a lot of scar tissue fibrosis. So I do everything I can to get them into remission in first 2 months. So this patient being sort of not responsive has really picked up a fair bit of scar tissue is my assumption. So increased the azathioprine, tripled the dose, and still the enzymes are sort of, went down. So although azathioprine was increased, liver tests really don't budge. This is now 150 milligrams. So it was stopped, and mycophenolate, that's the Cellcept, was added. The patient is on 30 milligrams of prednisone. And enzymes nicely improve. So just a rule of thumb, though, is if somebody has very high bilirubin, like 10, the first time they present with a high ALT and AST, I put them in the hospital, give IV steroids to get them in remission as soon as possible. Okay, 7 bilirubin is sort of high for me as well. This is something I would talk very carefully with the patients to make sure that I can connect with them, and they will follow my instructions, because I think there's a lot of monitoring, close monitoring early on. But I think that's the kind of patient you'd rather be on the safer side, admit and give high dose steroids to get them in remission. And then I think in this case, 12 weeks on ALT of 400, probably, I would have been more aggressive early on. But this patient really, the bilirubin was only 1.5 or 1. I think you can try as an outpatient. So here the point, though, is difficult to treat autoimmune hepatitis. The usual cocktail of prednisone and azathioprine may not work, in which case you have to go to this mycophenolate, mofetil, or tacrolimus Prograf. Anybody in the audience taking Prograf? So these are, sometimes we use Prograf because you become steroid dependent. That's the only way you can peel off the steroids. And it's lesser of the evils, and although it has its own set of side effects. So mycophenolate is also called Cellcept. Yeah, it's an expensive, I think that's what Terry was talking about. Genentech may give coupons. I'm going to skip this. So if you go into remission with medications, generally speaking, your life expectancy is the same as general population. Okay? So whatever it takes, if it means that you're having to take Cellcept, or if you're having to take Prograf, if you can go into remission, meaning enzymes are normal, your symptoms are better, and even if there is scar tissue, I think Dr. Lammert and Bobby have presented some scientific data as well. If you go into remission, even after having cirrhosis, you do really well, okay? But if you don't normalize your liver tests by 6 months, sort of, it's something you're talking with a difficult case here. And then also low albumin is a liver function test. And also if you develop autoimmune either late, I don't want to call it elderly, I'm getting there, or under 20 really as teenagers and 5s and 6, and I think it can be difficult to treat autoimmune hepatitis. I think mycophenolate mofetil, I think we've used this for a long period of time, really well tolerated, and we start anywhere from 500 milligrams to 2,000 milligrams, used a lot in liver transplant and kidney transplant. The only side effect, it can have some bone marrow suppression as well, especially higher doses, is the diarrhea. Except for that, it is pretty well tolerated. As a matter of fact, even the azathioprine is well tolerated as well, and no side effects. But keep in mind, just the diarrhea is the side effect. I'm going to skip this. I think I'm going to stop there. Happy to answer any questions you may have, though.
We're going to do a moderated session. I'm going to go through these questions that people have wrote down. If you want to write it down, or we can wait to the end and we'll see what gets your question as well. These are always interesting and great questions, mind you. I always learn a lot by seeing what patients are saying, so I think it's just amazing. Again, I apologize if I don't get to your question. I'm going to go through themes. Again, contact either me or Dr. Holden, Dr. Sammer as we're going out the hall if you need to get a hold of them. I think they'd be okay with that. So first and foremost, Abby wants to talk to someone that has AIH2. Where's Abby at? Okay, there's Abby. If anybody has AIH type 2 and wants to get to know her, I think she'd probably like to get to know you. So here's a good question. I'll take this one. Has any study been able to correlate, an increased understanding of disease with education and clinicians? And we hear about this all the time, and no. But I think this is a great point and underscores the aims of this group is education, not on a patient level, but also at a physician level or nurse or ancillary staff level. Let me just ask a question back. How many people have been offended or irritated by someone's inadequate knowledge in their healthcare world about their disease? Yeah, pretty apparent. So I don't know if it's communicability. What did you do to get this? And there's been markers, the idea that we need to change the word hepatitis, but realize it's just an umbrella term, again, for inflammation of the liver. But the interesting paradigm is with PBC that cirrhosis also has a bad nomenclature as well. So there's even a push that maybe we'll be changing PBC in the future. So a great point, but we should look at this and we should figure out how we can educate people better. John, you have a few questions in front of you if you want to go ahead and just say one of those.
Sure, absolutely. A question from one of the patients in the audience that says that they have autoimmune hepatitis and PBC and that their liver enzymes are normal, but they've found that another enzyme that their doctor is following, their lipase, continues to be high. Just to give people a little bit of information, lipase is something that we can see elevated commonly in the body. Lipase is often thought of as being a specific marker for inflammation of the pancreas, though it can also be seen as a marker of inflammation in the intestines and some other organs of the abdomen as well. One thing that comes to mind when I hear about the lipase being high is we've talked a little bit about the fact that autoimmune conditions can affect multiple organs in the body, and people with autoimmune hepatitis can also have other autoimmune conditions. And so for this particular patient, if their lipase is high, and knowing that the lipase can be somewhat specific to injury to the pancreas, it raises the question for me as to whether they could have autoimmune pancreatitis or injury to their pancreas as well. And that may be something that they want to have their doctor take a look at.
Absolutely. Thanks, Dr. Holden. Dr. Galray, where and how can you get obeticholic acid?
Only through clinical trials. Currently, it is not available for clinical use. You cannot get it at a pharmacy. As I mentioned, the studies are just beginning to emerge. We are one of the leading centers in the U.S. that run clinical trials using obeticholic acid. But as I said, it has to be vetted really well. The efficacy has to be confirmed in more than one good study. before it's approved for clinical use. And also the safety. The safety has to be confirmed by more than one study before the FDA approves it. So right now, if you're interested in the possibility of getting on obeticholic acid, you should find a center that offers a clinical trial with obeticholic acid. Mind you that if you enroll in a randomized controlled trial, it is not a guarantee that you will get on obeticholic acid. Some patients get randomized, as the name implies, to placebo. So it's not a guarantee that the patient will get. But that's the best shot, randomized controlled trial at a center that's enrolled, that participate in those.
Great, thank you. Next question, this will be for me. Was it decaf or regular? So this, this is a great question. I can tell you in our study we did not decide the difference between both. And I'll tell you, what even constitutes a cup of coffee if you're anything like me or Dr. Vupalanchi who just walked in? You carry a 20-ounce cup all day long. So it's an observational study. There has been further studies now and subsequent to look at dissection in these other diseases. Is decaf important? It may be important to, what do you put in your coffee? As Dr. Galway probably doesn't like, you probably put a lot of sugar and or cream. So these are important factors. So we don't know. But I think if you look at the overall data, and the biggest study for coffee outside of liver disease was a New England Journal of Medicine article back in 2013. And we saw if you hit 2 to 3 cups of coffee a day, you actually decreased your risk of mortality. In women, 13%, and men, 10%. This is all causes except for cancer. But it's an observational study, but it was very large. It's interesting. But if you drink it, I think it's okay. Next question. I'll take this one too. Are you going to publish or email this PowerPoint slides, or will they be available? Yes, they'll be available to everyone in this room at some point. We have yet to know how we're going to disperse these, but these are important. Not only the PowerPoints, but also the audio. So what I'm speaking right now will be available to you. Let me give one to Dr. Galway. This is a pathology question. If your liver biopsy says some cirrhosis, how do you know your percent of cirrhosis and what to expect due to cirrhosis?
That's an excellent question. So typically, you probably have heard of the different system we use for saying how severe the scarring of the liver is. We refer to scarring as fibrosis medically. So we use a scale from 0 to 4 to classify that. 0 meaning nothing, no scar tissue, no fibrosis or normal. 4 meaning severe fibrosis or severe scarring or cirrhosis. So when the pathologist calls some cirrhosis, they mean that they do see at least hints of it, meaning that the liver, as Dr. Holden showed you earlier, nice rows and rows of liver cells. The liver architecture, this architecture has been changed, destructed, so that it's no longer rows, nice rows, one after another. It looks like nodule or round areas or islands of tissue surrounded by almost circular bands of scar tissue. So anytime the pathologist calls a hint of that, they see these nodules, it is cirrhosis. Now, 2 important things to realize. Sometimes cirrhosis could be early, meaning that these bands surrounding the island of tissue are not complete or about to be completed. And the thickness of the bands is not too thick. Why is this relevant? The more advanced the cirrhosis is, what the pathologist sees on the liver biopsy, good liver biopsy, the more likely the patient will be dealing with consequences of damage to the liver. So thick bands, established cirrhosis, advanced cirrhosis, we're more likely to see liver failure coming up in the future and less likely to regress or melt away. Yes, I mean it. It does go back. It does melt away. So actually, early studies from the Mayo Clinic, Dr. Chaya, who trained me and trained Dr. Lammert, had published that in patients who have autoimmune hepatitis and respond to treatment, if they have early cirrhosis, not the very thick bands surrounding the islands, just the early bands, thin bands, they could actually reverse. They could get rid of cirrhosis with time. So when they respond to treatment, long term, you repeat the biopsy 2-3 years down the road, the cirrhosis is gone. These early bands that were forming to cause cirrhosis go away, sometimes completely, sometimes partially, but the patient may no longer have cirrhosis.
So I just want to, it's 10:45, so we are scheduled for a break. If you need to get up and use the restroom, there's still coffee and water, but we'll just kind of continue going through these questions if that's okay, so please excuse yourself. Here's a theme question, and I think Molly Bozick, who's now in the back of the room and going to do a pediatric session, could also talk about this, but the question is what to do with your kids if you have AIH and the potential for giving it to them. So there is this genetic component, but as of right now, there's no guidelines for screening for children with AIH. The only anecdotal data I can give you is a question I asked maybe 6 months to a year ago on my site was, do you have a first-degree relative? That would be mother, brother, sister, daughter, son that has autoimmune hepatitis. We saw about 4 to 5%. This is a very specific group of patients, obviously, but we may think that there is an increased risk, and certainly we see this with PBC and upwards of 8 to 10%, depending on the study. There is a first-degree relative with that disease. So I tell patients, unfortunately, I don't recommend screening, but I think we don't let symptoms go uninvestigated, maybe is the right approach. John, you have one other question there.
Yeah. So I have a question here. Does high level of glucose consumption have a negative effect on the hepatic metabolic pathway, potentially inducing hepatic strain, and is it a contributing factor to autoimmune hepatitis? The one thing I would just say is that one of the things that the liver is very good at is maintaining what we call homeostasis, or normal levels in the body. And so for most individuals, if you're out there and you're having a sundae every once in a while, or going out and having a Snickers or whatnot, our body is very good at maintaining normal levels. And so I think for most individuals, having a little bit of excess glucose now and then is probably not a bad thing, though we do know for some people who tend to take in more calories or glucose that this can have metabolic effects. It can lead to obesity. And the one thing I would say is that in those patients, they are at higher risk for things like the fatty liver disease that Dr. Gowrie discussed. And that in and of itself, though it doesn't contribute directly to necessarily autoimmune hepatitis, can have a detrimental effect on the liver.
Great. What is the difference between type 1 and type 2 and I think they're alluding to, is treatment different according to type? This gets back to the hammer and nail. It's not. So we use immunosuppression directed at both type 1 and type 2. And again, that's why the dissection is maybe not terribly important. However, we do see that there may be difference in outcomes. Unfortunately, the data has not been very robust. As you know, type 1 is already rare enough, but do a subset of group and where we see type 2 patients are at a much reduced frequency, it's hard to study. So all of our data is based on small sampling. Dr. Gowrie, I have a great question for you. And this one comes up all the time.
Sure.
Many people talk about pain on the right side where their liver is. Hepatologists like Dr. Gowrie seem to be unconcerned. Just kidding, I added. But we'd like to try to understand this cause. Can it be the liver, or is it something else?
This is someone who knows Dr. Gowrie. So I admit it, I do say that. It's a common complaint. The fact is, diffuse liver problems, such as fatty liver, fat filling up the liver, causing fatty liver, or autoimmune hepatitis, or even hepatitis C, do not cause pain. True, the liver is in the upper part of the abdomen, and more to the right side, but it fills up the upper abdomen. But chronic liver disease rarely is a cause for abdominal pain. So it is not. When does the liver cause pain? There are certain situations that there is either a nasty, aggressive, severe infection, for example, infection of the bile ducts. Someone with PSC saying that he has fevers, and I say he because it's more likely to be a male, has fever, chills, severe abdominal pain. We take that very seriously. It's an infection of the bile duct, and that could be life-threatening until proven otherwise. Focal problems in the liver, unlike diffuse problems, focal problems such as abscess, tumor, those could cause pain. But chronic conditions such as fatty liver, autoimmune hepatitis should not cause pain.
Great, thank you. Dr. Holden, what is the least toxic medicine to manage itching? Any thoughts?
Yeah, great questions. I mean, we commonly have to, treat the itching symptomatically, and a lot of the medications that we use or reach to first are antihistamines, things like Benadryl or hydroxyzine. And these are medications that we've at least used for long periods of time, and so I think we have a general idea of what their side effects are. Though I think for people who've used them, they know that there are side effects, particularly drowsiness.
Right.
And so unfortunately, the common medications that we use do have some side effects, but at least I think that we have a good idea of their profile.
Right. So certainly talking that we have a long list of things that we can use for itching, everything from bile acid sequestrants that really aren't absorbed to medications, as Dr. Holden said, that are antihistamine. They decrease itch. Other things, particularly naltrexone, but also other things like SSRIs may be important. Every medication has a theoretic risk. So again, it's always something that you need to talk to your doctor about. Dr. Gowray, if you have fatty liver, can this be reversed with weight loss and healthy lifestyle? This seems like a slam dunk for you.
Yes, the answer is absolute yes. And contrary to the common misconception, one really doesn't need to go bone and skin to get rid of fatty liver. Different studies have shown that losing about 3 to 5% of the current weight is enough to get rid of fatty liver. So let's assume a patient weighs 200 pounds. If they lose anywhere between 6 to 10 pounds and maintain it, that should be enough to improve fatty liver and get rid of it. Now, for patients who have the severe form of fatty liver, NASH, where there is, in addition to fat, there is inflammation and scarring of the liver, studies have shown more weight loss is necessary. So 7 to 10% is enough to improve that on the long run. So if you take it back to the example of a 200-pound patient, 7 to 10% will translate into 14 to 20 pounds weight loss. And we always say do it very slowly, don't rush it, because when you rush it, that has bad side effects on the liver, gallstones, etc., and also is not sustainable. So what we're calling for is just small amount of body weight loss slowly over time. That could reverse fatty liver.
That's great. Here's a question. This is a patient story. I was recently diagnosed with AIH. The last presentation spoke about the way you treat it. And it says, if you're allergic or have a bad reaction from taking steroids, what are my options? Maybe open to all three of us. And I'll say, well, what is a bad reaction? I think everybody may have a bad reaction to prednisone, depending on what you quantitate it as. But if it's a true allergy, then it's a little bit more concerning. We have other rescue agents to consider. Again, this would be a very rare occurrence that we would have to do. And then again, depending on the degree of inflammation, many may actually decide just to try to start on chronic long-term therapy in hopes that with time and increasing amounts of drug, that we actually can cause the inflammation or improve the inflammation. Now, you guys have any other thoughts on people not tolerating prednisone and getting inflammation under control?
Yeah, I mean, the one thing I guess I would just say is that we see all the time that people have a lot of difficulties managing with the prednisone, be it their blood sugars, their mood, difficulties with sleep. And when we run into some of these things as opposed to a true allergy, just to say that sometimes there are things that we can do either medically or behaviorally to kind of alleviate some of these effects to hopefully make them using the prednisone more tolerable for a period of time.
Yeah, that's good.
Another approach we may use sometimes is to take the patient off prednisone gradually and put them on budesonide or entocort. So the advantage of budesonide is that it is, essentially it has much less systemic side effects, which are the main problem with prednisone. So it has almost 99% first pass in the liver, so it doesn't spill into the circulation as much, doesn't cause systemic side effects like prednisone. The budesonide has a lot more data in European studies that it works, and sometimes they use it almost as an alternative to prednisone. The other approach to minimize the side effects of steroids or prednisone is to actually start double therapy from the get-go. For example, if it is azathioprine, start it from the beginning so that once the patient achieves biochemical response, we do the taper of prednisone slowly but early.
And so again, we're 5 minutes till 11. So again, just so we can all get up and walk around, let's do one more question. I'll keep the stack of questions that we didn't get to for the next kind of topics. And this is right at me. How will GRACE study improve the Dutch study? So a great question. how can we compete with 1,700? Well, I will tell you that at least our patients, including you if you decide to contribute to this, will be very phenotypically dissected, meaning we know the ins and outs of the AIH. It's not purely dependent on a diagnostic code, which we know historically is probably not a very good marker. We also, as you know, if you've done the study, we're going to talk more about it, but if you've given blood and saliva or one or the other, we've also had the associated environmental risk factor surveys. There's 3 of them. The benefit is you actually can start to look at the interaction between environment and genetics when you have it for the same person. I'll tell you the Dutch do not have this. So we are well positioned, and again, we need numbers. So we'll talk more about that. Thank you all. We'll take a break. We'll be back, okay? So one for me, it says, Craig, when are all your surveys available for pediatric patients going to start? So they are, so we can recruit down to the age of 6 years old. So if that answers the question. Dr. Bozic, if you want to start with one of your questions that you have, I've dealt you.
Sure. So there was a question about what is the incidence of autoimmune hepatitis running in siblings. A particular patient had children, 2 of the 3 were diagnosed, one with autoimmune hepatitis and one with ulcerative colitis. So there's not an actual incidence that I know of per se, but we know that autoimmune diseases, when there's a family history, that we have a higher suspicion for siblings. Somebody had mentioned with Crohn's disease, we know with Crohn's that there's about a 10% chance if a first-degree relative has Crohn's or ulcerative colitis, that a sibling could possibly have it. So anytime that there's a family history, either a sibling or a first-degree relative, we're really watching for signs or symptoms. As Dr. Lammert had said earlier, specifically with autoimmune hepatitis, that at least in pediatrics, there's not good guidelines as far as screening those kids, but watching closely for signs or symptoms and getting evaluation done promptly to make sure we're not missing something.
Great, thank you. Dr. Veen, is treatment with CellCept as effective as azathioprine?
So there's no head-to-head clinical trials comparing azathioprine and CellCept together. CellCept is a rescue therapy, as I said, unconventional treatment, and we go to CellCept when Imuran doesn't work or Imuran is not tolerated. You have the opportunity to titrate the dose of CellCept to the highest possible tolerated dose or highest efficacy dose, and if it doesn't work, we move on to the next drug. So. Unless there's a head-to-head trial, I cannot answer that question.
So the current approach that Dr. V has also kind of talked about is the use of azathioprine or 6-MP as a first-line agent. Ultimately, CellCept is what we're kind of the nomenclature of non-traditional or second line. However, at least in some of our work that we've done online, we're seeing kind of a change in pattern, at least in North America. We're seeing CellCept used a little bit more as first-line therapy, which it's unclear, and maybe it's a side effect profile. I'm not quite certain. But at least more recently, we saw at least 10% of patients were getting this first and foremost along with their prednisone or budesonide. But I think currently now we're using CellCept for patients that are intolerant to azathioprine, either the GI side effects or significant liver test abnormalities or abnormal cell counts. We will then transition to CellCept. And actually, if you look at those patients, they tend to do quite well. So this is at least reassuring. But again, limited evidence, we need to look at it a little bit better. Dr. Bozic, can you go with your next one?
There was a question if there was any correlation between newborn jaundice and autoimmune hepatitis. No clear association in that. Newborn jaundice is typically a different type of jaundice where the bilirubin, where the babies are jaundiced, the bilirubin is indirect, not a primary liver problem. So the normal newborn jaundice that you'll see when babies are first born in the first week or 10 days of life is a different type where the bilirubin that is elevated is indirect as opposed to a direct elevation of bilirubin that would be more indicative of a liver problem. Sometimes when babies have a direct elevated bilirubin, while autoimmune hepatitis is quite rare in infants, there are reports of it.
Great, thank you. Dr. Bublanchi, along with the risk of infection, can you comment on the long-term or lifelong use of Imuran, its side effects, et cetera?
We do get asked this question often, and I do have conversation. So Imuran, any immune suppressant, has a consequence of lymphoma in addition to infection due to suppression of bone marrow. But most of the data comes from post-transplant area, not necessarily from autoimmune hepatitis area. Some data comes from inflammatory bowel disease like Crohn's or ulcerative colitis, but that patient population by themselves are at risk for lymphomas. So I am not necessarily convinced that using Imuran for autoimmune hepatitis is at risk for lymphoma. I personally have not seen any. All the lymphomas that we have seen are in post-transplant area. So I'm not very concerned.
I agree. Thank you. And maybe, again, for you, Dr. V, what's the difference? We've talked about Imuran a lot. What's the difference between Imuran and 6-MP?
Yeah, the graph, the figure I showed, Imuran is azathioprine is converted to 6-MP. I don't necessarily know why we choose Imuran over 6-MP. In some patients, I've changed the prescription from Imuran to 6-MP when the patients didn't tolerate with muscle pains and that kind of stuff. But it may be marketing or familiarity, or that's how you are trained. But I do see that pediatricians use 6-MP much more than adult, and it may be just how the prescription pattern.
Dr. Bozic, any follow-up on that?
Agree. I think it's provider dependent. We have some providers that primarily use azathioprine and are just more comfortable with it, and others that use 6-MP, so really very interchangeable.
Great. For both of you, question for, I am in chemical remission. How often do you recommend I get my blood drawn to monitor this?
Yeah. Again, at what time point? If you have been in biochemical remission for 3 years, I'm like yearly is fine. If you just got into biochemical remission, I would like to, have better sense, maybe once in 3 months, once in 6 months. Really, some patients do undergo liver tests more often than they are needed. That's because they are scared and they want to make sure that nothing is missed, and it's easier to order blood tests for us from our side. So I think it is overdone, but at the same time, it's a comforting thing to know that we are on track. And sometimes if a patient comes from 3-hour drive and is not going to come back another 6 months, I do worry. So I may be more comfortable saying, hey, get blood work every 6 weeks or every 8 weeks. So it's
I think it very similar in pediatrics as well, depending on how long they have done well and their liver enzymes have been normal. Usually I will go every 6 months, sometimes to a year, but more from a comfort. Usually the parents and families want to be checked earlier. So at least every 6 months, and more acutely every 6 to 8 weeks in that very beginning stage.
Great. Dr. Bozic, if you want to do the next card.
There was a couple questions, and I'll have Raj, and if he can weigh in as well, about T-cell transplants or stem cell transplants for autoimmune hepatitis. Not yet that I know of in pediatrics, and peds tends to lag behind adults, but I don't know if...
These bone marrow or stem cell transplant are much more toxic than currently available treatment options for autoimmune hepatitis. So it's not going to fly unless there's some novel ways of manipulating T cells or B cells that are injuring the liver. So going after the bone marrow is much more toxic option compared to using oral drugs to control the inflammation in the liver. So,
same thing for inflammatory bowel disease as a sister disease. This has been attempted. Studies, I'm not an expert, but ultimately have really failed to materialize much of a true impact and maybe a little bit more risk, but there still may be some ideas for further investigation. So, great. Here's a question about biopsy. How often should we biopsy?
So, I restrict liver biopsy to the initial diagnosis, and very, very rarely, somewhere down the line, if things don't make sense, I do not use it to assess response to treatment because that information is available to me by blood tests, and I want to promote fibroscan to understand with regard to scarring in the liver. There is value in making sure the liver enzymes are normal, and not regular normal. What I mean by that is real normal ALT for a woman is 19, and for a man is 29. And if you look at your various labs in your hometowns, sometimes normal in Fort Wayne is 70. That is not normal for autoimmune hepatitis patients. And if you let that 50, 70 ALT over 10 years, it is progressing. Low grade, it is progressing. And then how come, doc, I'm taking my Imuran, and how is it that I got cirrhosis? Well, what everybody thought in the past, oh, as long as the liver enzymes are less than 100, you should be fine. It's not fine. You need to have normal to make sure that liver is normal.
Absolutely. So I think there was a recent study just here in the past couple months by a German group. And of 25 patients that they allowed to come off therapy after 2 years of normal liver tests and a biopsy, they actually had normal liver biopsy. They had 13 patients come off therapy. And the people that relapsed were the people that did not have bottom basement levels of AST, ALT, and immunoglobulin G. So I think we may see this change a little bit as far as what are our targets. But I think I'm not necessarily happy with an upper normal limit value for AST or ALT or IgG for that matter. Dr. Bozic, I don't know your
And
thoughts.
similar in pediatrics. The only other time that sometimes we'll do a liver biopsy is if we are considering taking off treatment and then doing a biopsy before then. But
Great.
similar situation for liver enzymes in kids, that the normals vary widely and that we want normals to be truly normal, low levels.
And that actually leads into a question what you and I just talked about is, do I need a liver biopsy if I'm going to go off therapy?
In pediatrics, we usually will do a liver biopsy before coming off of therapy. I think it's somewhat controversial, but at least at our institution, we'll do a biopsy before coming off of therapy.
Dr. V, what are your thoughts?
Well, the proposed criteria is 3 rules: normal liver enzymes for at least 3 years, normal IgG for 3 years, and liver biopsy showing no inflammation. Then you can talk about liver discontinuation. I have done it reluctantly. I'm losing enthusiasm, but hopefully FibroScan will give us some idea. But also, when we review data from previously published trials, one has to be careful. If they included drug-induced autoimmune hepatitis in the initial phase, and they claim that these patients came off the drug, and we are using that information to use for patients who had regular autoimmune hepatitis, we're going to burn ourselves. So I always, when I inherit a patient with autoimmune hepatitis, I always question, was the initial diagnosis truly de novo autoimmune hepatitis or some drug-induced autoimmune hepatitis? And one has to carefully review that data.
Right, I agree. Maybe a question for both of you. How often does this facility use tacrolimus or FK506, also known as Prograf, to treat AIH?
My experience, and I've been faculty for 3 years, I've never used it, but from the other 2 hepatologists, I think I know of 1 case, so it's quite rare in pediatrics.
Yeah. I personally have 5 patients, but I'm sure each of us have 4 or 5, not a lot, but we are comfortable using it post-transplant, so it comes very easy to us to use these drugs, but for a physician in the community, they're never going to use it because they're not familiar with the drug at all.
Gotcha. Going off prednisone, the question is maintaining low dose or getting off better, and what would drive this decision making?
In my mind, no patient should be on prednisone. That's slam dunk. There's no. Sorry. Yeah, there are horror stories here. Some of my patients are here. There's no way, but there should not be an excuse. Very reluctantly, as I said, because of insurance issues, I had to leave a patient on prednisone, but I tried to keep it under 10, which is like a physiological dose, and doesn't have much of consequence on the bone, cataract, blood pressure, diabetes, as long as you keep it less than 10. but that is out of desperation because I cannot get any other drug. But otherwise, really, I don't have any role for prednisone in maintenance. Yes, I use it in acute. Hopefully, time will come when we use Cellcept as a substitute for prednisone because Cellcepts act fast. Imiran doesn't. We could, we have budesonide now, but we could use Cellcept.
So in that regard, this whole idea of a quick wean versus a slow wean, I think we're getting at it.
Yeah.
The question is this a trend that we're seeing people do more of a slower wean versus quickly?
I think people in the past were comfortable with prednisone because they didn't have anything, and it didn't matter if the patient complained with the side effects because they were still, oh my God, we are still able to save the patient.
Right.
Why are you complaining? Sort of attitude from now is like quality of life. Now our patients work, our patients they need to do their jobs.
Absolutely.
And if no job, no insurance, and
Right.
then bottom line.
Let's just do a few more questions. Sorry. Dr. Bozic, if you want to.
Somebody had asked about if there is any apps recommended for patients for tracking labs. Not necessarily for tracking labs, although the portals that are coming will be helpful. We'll use phones for kids, just even in their notes section, just to list their medications and their dose and why they're on their medications. For compliance issues, we'll have kids set alarms and things on their phone to remind them to take their medications. I did have a patient tell me about an app called Simple, S-Y-M-P-L-E, that sort of tracked symptoms over time that they liked. But other specifics I'm not aware of.
Okay, great. Dr. Vupalachi is also an expert in drug-induced liver injury, somewhat similar to the drug-induced autoimmune hepatitis. This question is, when you say drug-induced, does this mean the patient's currently on or very recently on the drug? Could it have been years?
Yes, typically drug-induced autoimmune hepatitis have long latency period, unlike the regular drug-induced, which is augmentin prescription, and 3 weeks later you're jaundiced. That's the typical DILI that we call. But drug-induced autoimmune hepatitis, the classic example I gave is old ladies on nitrofurantoin for 3 years, 5 years, and then presenting with cirrhosis, or teenagers, acne, on and off minocycline. They have been on and off for 2-3 years. They use it when they need it, and then they present with autoimmune hepatitis. And oftentimes it's confusing because, well, they've been on it for 3 years, why now? But that is the typical signature.
Yeah. So this question is, with just a few more here. When AIH is diagnosed in the setting of fulminant liver failure and cirrhosis, followed by biochemical remission, so that patient got better, will that cirrhosis always progress? I'm guessing they mean in terms of liver function. Will the cirrhosis always eventually lead to total liver failure and transplant?
Yeah. So again, it's a degree of collapse in the liver that happens at the time of acute injury. If the collapse is not a lot, the liver will reverse. All the fibrosis will disappear as long as we maintain the biochemical remission over time.
Yeah.
But if the initial injury shows a lot of collapse, the liver is disorganized. Even if the function comes back, the blood flow through the liver is not the same way. So there is congestion buildup, and then there is evidence of portal hypertension, meaning the blood cannot flow through the liver. It has to bypass the liver, and it uses the veins in the esophagus to go back to the heart. So there is backup and stuff like that. So synthetic function will improve, but the consequence of messed up blood flow through the liver, they remain. But those can be addressed. Usually there is a good prognosis. We don't really have to deal with liver transplant or anything like that for those patients. But we have to be one step ahead of the game and intervene to prevent complications.
Right. This last piece from me is someone that was diagnosed recently and started on high-dose prednisone and has been tapered, and his numbers have actually improved dramatically. He had the blood test, which I'm assuming that he or she is TPMT, and the doctor is worried about starting Imiran. What are my options? A little bit overlap there, but maybe Dr. V, if you talk about monitoring dose reduction.
Cannot use Imiran? at all.
Well, so I
Yeah.
think the doctor is worried about using Imuran because of whether it's a low TPMT
Okay.
or intermediate TPMT.
Well, we have the option to go to Cellcept. Budesonide monotherapy, I do not encourage that. Eventually, after using budesonide for a couple of years, there may be enough steroid exposure to the body. So Cellcept and taper the prednisone.
Yeah.
Cellcept monotherapy should be fine.
Yeah. Dr. Bozic, is there any other notable things in your pack there?
There was one question that I don't know if Raj might be able to help. Should men avoid fathering children when on azathioprine?
I don't think there's any specific recommendation. Azathioprine takes 6 weeks to kick in, and even if you stop, it takes another 6 to 8 weeks to kick in, to go away from the system. Its most effect is on bone marrow, not cell cycle per se, so I'm not sure if it is concerning.
I don't know the definitive answer, but as Dr. Bozic and I were talking about, this agent has been known to lower sperm count, so you may not get pregnant in the first place, as a possible male fertility drug in the future, maybe. But I agree with you. I don't know if there's great data. Well, we're going to wrap up for right now. We're going to go to lunch. I and some of other presenters may stay around for lunch and definitely can answer questions. Lunch will be actually in the dining hall that's connected to this facility. We'll just have to go out to the back hallway, and you'll follow all the way around, and there'll be people to help guide you. But it's a new cafeteria, and supposedly it's great, so hopefully you enjoy, and it's on us, so great. Thank you. It seems like there was a lot of transplant questions. There were a few pregnancy ones, and I actually just got handed a few pathology. Let's start with a transplant because there's a little bit heavier on that. Dr. Gabriel, is the criteria for liver transplant the same for children as it is for adults?
So that's a very good question. I'm an adult hepatologist, and I really haven't been involved with pediatric liver transplant. Usually I would say with kids, in a situation where there's not necessarily sort of birth defect situation in terms of cardiac anomalies or things that would, physiologically make it much harder for that baby or child to get through a surgery. I would say if it's just liver disease only specific question, I think the bar is really quite a bit lower because children are in general much healthier than adults. They haven't had really the ravages of time that give us some of the contraindications that we see in adult transplant world, whether it's substance use, heart disease, lung disease. So in general, it's, I would imagine it's less in terms of things that limit candidacy.
Right. Thank you. One more for you, Dr. Gabriel. So what are the signs? You talked about kidney disease and causing problems with these drugs. What are the signs that immunosuppression are impacting the kidneys? And is this a common? Yeah.
Yeah, so that's actually a very important question. That's sort of one of the main things that we sort of our jobs in the post-transplant follow-up scenario is. There's really not much in the way of symptoms. We have to do the lab work. It's really, that's why the labs need to be followed. In our patients who have problems with kidney function, we tend to follow them much more carefully as far as frequency of lab testing, so maybe more on the 2-month side of frequency if they're doing extremely well and mild dysfunction. We will often, if not invariably, get a kidney specialist involved. That's usually at least someone locally, and oftentimes getting one of our transplant kidney specialists also involved. The key question there is what can we do with immunosuppression? So as far as, the other issues, blood pressure, medications, if there's diabetes, using ACE inhibitors and what have you. So there are like universal things that can be done for kidney disease, but we also really are always asking ourselves, are we on the right immunosuppressive agents? Is there a different combination that's going to be less toxic? Should we be using different targets, or should we even be changing altogether to another agent?
Great. Thank you. Dr. Cummings, my biopsy showed no granulomas readily identified. What's this tell you?
Well, I'm not sure what context we're talking about.
Unfortunately, yeah.
If it's in autoimmune hepatitis, granulomas aren't really a part of that. If you were to see granulomas, you might worry if they were in the right context. It could be a primary biliary cirrhosis complicating autoimmune hepatitis. There's a number of drugs that cause granulomas, so we'd have to look at the medications you're on to see if there were granulomas that could be related to that. I normally don't mention that there aren't granulomas. I only mention when they are there myself. And
Right.
it could be other things like infection. If you saw granulomas, it could be sarcoidosis. There's a number of other diseases. And
So I guess the point being is put it in the context, particularly what the physician is trying to rule out for your own medical condition. Dr. Sozio, if a woman needs a surgery, a hysterectomy for that matter, are there increased risks for having a flare with AIH with surgery that you're aware of?
In general for
Yeah.
surgery?
This is for a hysterectomy.
I think anything can certainly trigger a flare, and sometimes around the time of surgery, we debate whether or not to, hold some of the immunosuppressives. Some of them, like sirolimus, can affect wound healing, and so oftentimes we'll try to switch them over to something else. So it's not a prohibitive risk. I mean, I wouldn't say not to have the surgery because of the risk of flare, but certainly it'd be something you'd want to keep an eye on afterwards, monitoring liver tests.
Absolutely. Dr. Gabriel, being immunosuppressed, are there any special precautions I should take in daily life?
So no, not really, actually. It's really mainly common sense stuff. Early on, post-transplant, oftentimes, we'll see patients going around with masks, and so dust is particularly something to be aware of in the very early period when there's a lot more heavy immunosuppression taking place, and things like fungal spores and things in the soil that can be problematic are really worth being careful about. But beyond that early period, it's really just mainly common sense, and no, travel to your heart's content. The only thing that I would say different is interesting travel. So sometimes someone wants to go to Africa or a non-developed country, and in those situations, actually, I will routinely refer them to an infectious disease specialist at our center, who appreciate the consult because it can be quite interesting as far as vaccinations that need to be given. So if you're planning interesting travel, yes, please let someone know, and things can be done to minimize risk.
Great. Dr. Cummings, I want to combine two questions for you, and this is a drug-related question. The first one is, how does ibuprofen or alcohol, for that matter, affect liver cells, maybe from your perspective? Mm-hmm. But then the kind of follow-up is, how certain you can be about autoimmune hepatitis in the setting of possible drug? And what do you look for? How confident are you?
Well, like I said in the discussion, that the diagnosis of autoimmune hepatitis is a combination of things. So there's the clinical parameters, and then does the histologic pattern fit with it? So when I get a biopsy, I just report out that it's a chronic hepatitis, and I tell you how much activity there is and how much fibrosis there is. So those are the things I give you. If it has the histologic features, the interface hepatitis, the plasma cells, I mention those things, rosettes, so that you can score the thing appropriately. But I can't tell all the things, the autoimmune hepatitis, apart from all the other things that cause chronic hepatitis. And I didn't mention all those. There's a lot of things. And that they can look very similar. And like I said, the drug reaction, you can't distinguish it. Ibuprofen per se does not give you histologic changes in the liver that are recognizable as such, so I can't address that. Alcohol is a very characteristic pattern of changes. It doesn't look like autoimmune hepatitis, so I'm very confident telling those things apart.
Right.
So.
Excellent. Dr. Sozio, what do you think? Do you think someone with AIH should see a gastroenterologist or a hepatologist, or neither?
I mean, I would prefer a hepatologist because that's my area of specialty. It probably depends in part on how easily controlled the disease is. So, there are some people who the autoimmune hepatitis is very well controlled on minimal immunosuppression. There are some people that it's very hard to control, and I think that's also probably a discussion with your physician. If you're seeing a gastroenterologist, how comfortable do they feel with the management of it?
Yeah. Dr. Gabriel, I handed you a few questions if you want to cycle through those.
Yeah. This was another very good question. Regarding transplants, why are only 470 live donor transplants performed? I would think this number might be higher considering the long wait for deceased donor transplants. I realize that not everyone has a family member who is a match, but still 470 seems very low. So I think that's actually a very good question. Probably even more pressing is some recent information suggesting that autoimmune hepatitis with live donor liver transplant might actually fare better in the long run compared to deceased donor, maybe having that genetic match, if you like, between the donor and the recipient may have something to do with it. Maybe condition is not as bad because you're getting to it early. But in terms of answering the question, honest truth, I don't know. Culture has a lot to do with the type of transplants that are done. For instance, in Japan, they're almost all live donor liver transplant. There's just no donation of organs. And so I think that, we've had a deceased donor culture in the U.S. As far as the live donor transplant, it's not necessarily an easy transition for a deceased donor transplant center to make. There's some expertise that has to develop. A lot of the data that we have is really anecdotal, and so there's just not large numbers, and a lot of things that we do in transplant really are gestalt and clinical sense, and a lot of, again, teamwork and discussion of tough cases. What we do know with live donor transplant, that sort of started in the late 80s, is that expertise has really improved quite a bit. And it looks like there's a certain threshold. You have to have done about 15 to 20 live donor transplants to really start getting pretty good at it. And that continues to be a bit of a threshold. So if anyone is considering live donor transplant, probably looking at the center volume, and it's probably more surgeon volume, becomes relevant. The big question oftentimes for the patients themselves, at least when I bring it up with my patients, because we don't do live donor here, and if they have a low MELD score, and I don't really envision them getting an organ, but I feel that their condition is too advanced to really wait the amount of time that I think it's going to take, I'll bring up live donor with them and just explain it as a non-live donor transplant person. And for a lot of patients, they really don't want any risk falling upon any of their family members, even if it's relatively small. The donor risks, I think, are worth mentioning in this light. Vascular risks of clots or thrombosis are about 2%. Biliary complications, which is bile duct problems that require further surgery, is about 6%. So these are, I would consider, fairly serious complications. We're talking about 8%. Mortality is very low, but there is that donor risk, and that, in my own experience, has been something that has limited a lot of discussions with patients, at least. But I think the numbers should grow. The data is looking good here recently that live donor transplant actually does quite well in the long run and looks to supersede deceased donor transplant outcomes. So I think the numbers will increase.
Great. I'm going to ask you to continue on with the next one. There was some concern earlier that we haven't talked about alpha-fetoprotein and monitoring for advanced liver disease. Could you just speak about that question, please? Sure.
So this is an interesting question. Is it bad for levels of alpha-fetoprotein to fluctuate, or what could that mean? And the individual mentioned that their values were going up at least tenfold compared to normal values. So this is probably a general hepatology question, not specific to transplant. AFP in the world of liver disease is mainly used, or at least considered to be used in the setting of screening for liver cancer, this hepatocellular cancer, which is the most common form of liver cancer. Typically, it occurs in someone with cirrhosis, so that's a group of individuals that are at risk, and as physicians, we're always screening and doing surveillance studies, so that's where this AFP test comes in. Unfortunately, it's not very sensitive or very specific for HCC, and the ASLD, for instance, just to give you an idea, a couple of years back had dropped it off their guidelines in terms of surveillance, so it wasn't even necessary to do. I think that a trend of a rising AFP should always be concerning in anyone, and probably would prompt us to look very hard for a liver lesion in someone who is at risk. Fluctuating AFPs are more interesting. I'm not quite sure what to make of that. And keep in mind, AFP can come from other places as well. So when we can't explain it in male patients, for instance, we always consider things like testicular cancer. But a fluctuating up and down probably doesn't sound like a liver cancer. I don't know the explanation, but it doesn't sound like the typical behavior we see with liver cancer.
Right.
I don't know if...
I agree with you completely. So we have just maybe 2 or 3 more questions, and then we'll take a 5-minute break just to give you an idea. I did get a few questions about supplements. I can answer these, but I'm not going to. I'm going to wait for Dr. McKee to come tomorrow, who is going to be our complementary alternative medicine speaker. So I'll hold those for tomorrow. I've also streamlined a few other ones, and the first one for Dr. Sozio. This, I think, speaks to the idea of portal hypertension, and the question is how can an enlarged spleen affect both mother and fetus during pregnancy?
Okay. Yeah, the enlarged spleen isn't, there isn't harm from that standpoint. The risk, as Dr. Lambert said, is more with the portal hypertension. And we know that the risk in a woman with cirrhosis, there is a higher risk of developing complications from the portal hypertension, namely variceal bleeding is probably the biggest risk. And so there are recommendations that even before a woman gets pregnant, that we should screen for varices if the woman has cirrhosis. And then in the second trimester, again, because actually during pregnancy, the blood flow to the portal system and the portal vein increases. So we know there's a higher likelihood that the varices can get larger. The management, if they're there, is up for debate. I think, I guess I would feel more comfortable with doing banding, variceal banding, where we actually, during the endoscopy, put a rubber band on those varices to try to eradicate them. There's some talk in the literature of using beta blockers, but there's risk both for the mother and the fetus with using that, so I think I'd feel less comfortable with doing that. But certainly if you have portal hypertension, the risk of having a complication during pregnancy does go up a little bit.
Great. Dr. Cummings, two more for you. How do you know if a biopsy is adequate? I was told that my biopsy is inadequate and maybe I needed another biopsy.
There are published criteria for adequacy of a biopsy, and the first paper I referenced is on the the American Association of Liver Disease. It's on their website, and you can read that. And it's for radiologists, hepatologists, internists, and pathologists, and it kind of goes over the criteria for everything. And so you need about a 1 centimeter long core of tissue, and it should be from at least a 16 gauge needle, or at least an 18 gauge needle. That's the minimum. So if you're 20 or 22 gauge, that's too thin, and you can't judge the fibrosis there because the portal tracts span the entire width of the core, so you can't tell if there's bridging or not. So when they get too thin, that's not adequate. If there's less than 10 portal tracts or less than a centimeter of length for that, that's also probably not adequate. So we do the best we can with what we have, but realize that I will say that the sample is, less than that when it is.
A quick story, initial biopsy report was stage 1 to 2, mild to moderate fibrosis. However, when I switched to a doctor, it sounds like a second opinion was done, or a reread was done, and it came back as stage 0, no fibrosis. How's that possible?
Well, was the same biopsy or a different biopsy?
This looks like the same biopsy that was reread.
Okay. Well, reading liver biopsies can be a little bit tricky if you don't do it. So I see about 700 liver biopsies a year myself, but most pathologists in private practice may get, maybe one a month. So there is a learning curve in dealing with that. I think, there's been difficulties in the criteria. Some people don't always understand all the criteria. It's sort of a subspecialty thing. So I think if there's ever a question, it's best to have the biopsy read by as experienced a liver pathologist as you can find.
So is that a reasonable question for patients to ask their primary
certainly.
hepatologist?
Who's reading my biopsy? How much experience do they
Yep,
have?
I think it's completely appropriate.
Yeah.
So I commonly have
Hopefully-
Dr. Cummings reread all of my biopsies. Last question, I'm going to handle this one if that's okay. If you have normal liver enzymes for years, can your liver scarring worsen, or should it stay the same or get better? That's a tough question. Actually, there's some interest in this from our group too. This is anecdotal data, but we shoot for for normal enzymes, and we've talked a little bit about this. That is our goal, also low immunoglobulins. However, if you look at biochemical responders, meaning normal liver tests within a year, and you watch them long term, there is going to be a proportion of patients that will still progress with more advancing fibrosis. In our cohort, we had approximately 150 biochemical responders. Actually, in follow-up of a median of about 7 to 8 years, we saw fibrosis progress by looking at end-stage liver disease findings like varices or ascites or encephalopathy in about 10 to 15% of patients. So I think this highlights the importance that maybe AST and ALT are not the best predictor, or maybe that we need to be shooting for a lower AST and ALT or a lower immunoglobulin G. So we'll leave it at that. When we take a 5-minute break, and we'll see you back here. We had a fury of questions for nutritionists and integrative medicine specialists, and some really good questions for also the caregiver support. We talked about this yesterday, about this mysterious right upper quadrant pain. I had posed a question to Dr. Gare, and we got a few questions about this. And one, there was a request that if everybody who experiences some fleeting symptom of right upper quadrant pain, either chronic or acute or intermittently over a week or month, can you raise your hand if you're willing to do so? So you can kind of see this kind of establishment of problem. I want to then kind of toss it to Dr. Mackay, and the idea is the question, can acupuncture be something that we can consider for this chronic pain that we may or may not think is related to liver disease?
Where do we think it's related?
I don't know.
So
we see it commonly. I think ultimately there's been hypothesis about liver involvement, particular capsular, but again, more of a chronic process. Poorly understood, I think, is the key part.
So there are, I would say, a couple of things that you could think about with respect to that. One is there is what's called a cutaneous visceral and a visceral cutaneous reflex. So as anybody, almost everybody knows that for a warning sign of heart attack, you can get pain in your left arm, your jaw, your shoulder. That's a radiating pain away from where the pain is coming from. And it has to do with the way nerves enter the spinal cord and get sent up. The same thing can happen where you can develop kind of superficial manifestations of internal pain and internal manifestations of external pain related to how the nervous system runs tracks next to each other as they come together. So I see a lot of people that would appear to have odd pain sensations away from the location, which makes sense from that standpoint. Another standpoint is the sense of worry and assignment, that individual's attribution to discomfort. One of our colleagues, one of our most respected colleagues in our department, is Kirk Krunke, and he studies symptoms. And one of the things that Dr. Krunke says is that the number of symptoms an individual reports is a SED rate, is an indicator of how much mental health, emotional concerns they have. And so it may be viewed as a concern that they know that this disease process is going on, they're not sure how to express that concern, and then it comes out as pain. And I see that a lot in our pain program, it's a sign that says, hey, I need to pay attention to this in a different way. So can acupuncture address any of those? Yes, yes, and yes. There's a sense of relaxation, so that if someone is going to do, say, a relaxation technique, we can put a few needles in the ears to augment, to enhance that sense of the nervous system that says, just chill out for a minute. It's not that bad. If I put a needle in the stomach 36, like I showed in the slide, or the one in the thumb here called Hegu, it'll generate an analgesic effect, and it doesn't discriminate whether it's one that you're worried about, one that you're not worried about. It will have a generalized analgesic effect, so that that type of symptom can be addressed from a concrete organ dense standpoint, from a referred standpoint, or really from a psycho-emotional reflection of concern onto the body.
Great. Dr. Montero, can we just change gears just briefly about pain and more about the caregiver? And this is a very simple question. If I'm a patient, how do I tell my caregiver it's just too much? They're being overly burdensome, I think, is the highlight.
I'm sorry, just to clarify, how do I tell my caregiver it's too much, meaning the caregiver's efforts are too much?
That's what it sounds like.
Okay. So I guess I would interpret that in two ways. The caregiving might be a little overwhelming, or the experience might be a little overwhelming. And I could see where both might easily be the case. Let me first address caregiving. I think it's open communication is really important. I mentioned before, often I think people, I guess anecdotally in my practice, I've seen people often feel the need to hide from their loved ones how they're feeling. Usually it's out of a sort of loving sense of not wanting to worry them, not wanting to increase their anxiety when they know they're already worried about their health status. But also you have to live with that person after you've told them something intimate and awkward. You go home together usually. So not wanting to inflame situations or not wanting to inflame their own emotional experience, if I'm making sense. Either way, my experience is that being open and direct is most helpful. So, usually you guys probably remember some of these basic communication coaching methods, like having the bookends, start with something positive, put what you need in the middle, and end with something positive. So I would start out by explaining, how much you appreciate, fill in the blank with your own feelings, how someone is making efforts to help you. I'd use I language, like this is what I need, I'm experiencing, what would be helpful for me. Instead of when you do this, when X happens, this is how I feel, and offer them a solution. This is what I would really like. What would help me the most is, instead of checking on my diet every day, is if we'd together post some guidelines, and then I'll make healthy choices from there. So it would be most helpful to me if we'd have some general reminders, but not, when I feel there's criticism, for example, over what I'm eating, that makes me feel, fill in the blank, small, criticized, whatever. And then that other bookend, it is so helpful to me to know that you care, and I appreciate your wanting to be of support. So let's follow up by posting that on the fridge, and I'll do my part to follow, be a good steward of my own health and follow those guidelines. Does that make sense? For coping with the experience being overwhelming, I would, again, encourage open communication. Talk to your partner about how hard this is. This is usually something they're probably already attuned to and connected to. There's some benefit just to processing that. It's called cathartic benefit. I saw somebody put their hand over their partner's mouth. This must already be happening to in some families. But the idea is expressing your feelings is a helpful, healthful thing. And as needed, also seek out professional support for that. There is nothing wrong with having, in fact, I think Lot's right, with having some additional support. Someone who can help build on the coping skills you're already bringing to the table. It can help you get to the goals you want, feeling like this is less overwhelming, feeling like I can manage this, break it into smaller steps so that it's achievable, and then you get that synergy of gains I was talking about. So hopefully I've helped to answer that, but I'm glad to follow up if I can.
Yeah, no, I think
Thank
that's
you.
great. Ms. Hansen, so a few kind of quick questions. I've heard that cheese loses lactose as time passes. Is this true? And if so, what point would it be safe to be eaten by someone who is sensitive to lactose?
That's actually a good question. I can't actually speak on the amount of time it would take for certain cheeses to lose lactose, so I can't really speak on that piece, although I do know, as I listed in the table, that there are some cheeses that are higher in lactose content naturally, so I would try to stick to the ones that are lower in lactose by naturally. Most cheeses in themselves don't have a high lactose content, so I usually tell my patients, if you are lactose intolerant, the things that are probably going to cause you the most discomfort is going to be the milk and the ice cream and those kinds of things. So cheese by nature doesn't have a high lactose content anyway, so it may not cause you discomfort, but I can't exactly speak on each individual cheese and the exact amount of time it would take for it to lose its lactose content. So I'll have to look into that, but definitely willing to.
Is it true the more liquid or soft the dairy product, the more lactose?
Yes.
Okay.
Yes.
So maybe that's a good rule of thumb for
Yes.
everybody to have. Also, in follow-up about some other nutritional things directed at you, Ms. Hansen, thoughts on starting lemon water and also green drink, and question about mixture and thoughts, and maybe Dr. Mackay can also comment.
I've heard of a lot of people doing like juicing and making those kinds of drinks. I don't have any real specific recommendations about those kinds of drinks. I mean, I think some of those types of things are kind of like a fad dieting technique, so hopefully you're not using it as a dieting technique. I don't have any specific, recipes that I recommend to my patients as far as, drinks, or smoothies or that type of thing. you know, I would just say if you're doing juicing of any kind, making sure that you have, you know, a balance of fruits and vegetables and fiber in there and protein as well, to make sure you have a balance in your drink. I don't want to use those types of drinks as meal replacements. I would use it more as, you know, your source of hydration on top of what you're already eating, if that makes sense.
I think that's great. Please.
So I warned Dr. Lammert that at some point I was going to contradict and offend someone, so this is my opportunity. When you have what many of you have is a life-threatening illness, sometimes it does require, again, that you get out of the litter box. And there are opportunities to profoundly change the way assume that half of what I presented was true in terms of the leaky intestines and the innate immunity and the immunity. There are profound benefits to juicing. And I agree, you should never ever juice for a lifetime exclusively. But if you want to set up a corrective diet plan for autoimmune diseases, I believe that an intelligent juicing approach then transitioned into a more inclusive, regular diet is a reasonable thing to do. Just as the FODMAP diet is one form of an elimination diet, there are other elimination diets. The juice would be one example of elimination diet, so that you eat things that are nutrient rich and offer very little offensive ingredients, and then slowly then add back to your diet. For instance, there's generally, say, low dairy for a lot of stuff, and you could have soy cheese, which shouldn't have any lactose in it, right? Mm-hmm. And you could substitute that. And then to do this, and one of the things I would say, has anybody seen the documentary Fat, Sick, and Nearly Dead? Profound autoimmune disease. That's what they had. They had an autoimmune disorder that gave hives so bad that they developed ulcerations. That was transformed largely because they thought it was possible, leading to the sense of hope and optimism that allows you the motivation to do it, but driven through an abrupt change in the diet, getting rid of the crap, putting in the good, and then finding what the body can tolerate. Can they tolerate a little bit of wheat? Can they tolerate a little bit of dairy? So that I think that for serious illnesses, it would require oftentimes a serious adjustment in the nutrition. Juicing might be a good part of that.
Excellent point. So one common theme I'm seeing through all these questions is talking about alternative therapies, including like turmeric, and how you actually take that either in capsule form or in whole form through foods, and also these other supplements as well. One, what are your folks' thoughts on supplements in the capsule form or the raw ingredient? And then also, where's a good resource for considering dosing for some of these alternative agents?
You can go if you'd like to.
I'll speak for her. So if you want the doses for ginger, I have those. You want to consume a fair amount of the extract, so roughly about make about an ounce of ginger, and you can make a decoction. You can buy the ginger extract. You can do dog therapy in the back, which I really like for stress reduction. But it's difficult to know how much. If anybody, and I don't want to just kind of publicly do it, but if anybody would email me, I would give you my thoughts about what the doses are. Because there are some other things that I didn't mention. There are extracts, oregano, thyme, some vitamin D dosing, other things that there's a set of medicine called functional medicine. And the basic parameters for this are thought to be understood, at least within that field of medicine, to address that. But it is really an uncertain science about, do you need 1,500 milligrams of ginger and how that ginger should be prepared? Can you buy the turmeric at Whole Foods, cut it up, cook it, and eat it? There are a lot of great ways to get these in. And from my standpoint, and I'm going to assume from Catherine's, that the more you eat healthy stuff, the better. And if you can get cinnamon in 4 times a day, do that. If you can get garlic in, if you can get cayenne in, and ginger and turmeric, it's wonderful that way. It's more natural, it's less processed. And for some of these things, for garlic, it has to be prepared in a certain way. So some of the extracts neutralize the allicin, some of the active ingredients. So in some ways, the processing can deter the body from getting the benefits it could get by eating it naturally.
Great. So what about the concern of interaction? A number of us here in the room are on significant immunosuppressants. What's a good resource to think about interaction, or should I be concerned?
I really cannot offer you a terrific resource for those interactions. You can get on the site that was given to you, the dietary supplement site, the CAM site, to see about that. But I think we have a gentleman in our department, Dave Flockhart, who has published how almost everything is metabolized. He's the head of our clinical pharmacology division. And if you look up Dave Flockhart and look up his tables, that would probably give you the best understanding of how some of these would either lower the medication or increase. And I'll just give you a devastating example. St. John's wort was everybody's darling 12 years ago for depression. I was in our former dean's office, Dr. Brader, who used to be our chair, and I was in for my annual review. And NIH was calling him up saying, what is this stuff about St. John's wort interfering with how the protease inhibitors work? So that a lot of depressed individuals, appropriately so, with a new illness of HIV and AIDS, their titers were going through the roof because they were treating their depression, their mood disorder, with St. John's wort. Similar things have happened with transplant patients who have received an organ and they're on immunosuppressants. And then they take St. John's wort, which increases the metabolism of that agent that's designed to help you keep that organ, and then you reject the organ. So St. John's wort is very well known at this point for no longer being the darling of the herbal world. And it is critical, if you're on strong immunosuppressants and you have an organ, that you look that up and be very hesitant.
Great. Dr. Montero and Dr. Mackay, because I know your background, Dr. Montero, what things would you look for people looking for yoga or other mindful kind of instruction? And then also, Dr. Mackay, looking for in an acupuncturist?
Here, you've been on a good trend. You want to go?
So the evidence is really, even though I wasn't, the evidence is clear. Get a teacher. You can learn a lot by yourself, but teachers, facilitators really help. The acupuncturist, what I would say, is get someone who's familiar with significant medical illness and wants to know. Oh, you'll be fine, we can do this. No, be very careful. Acupuncture will not interfere with much at all. You can be on full blood thinners and get acupuncture very easily. I've had just as much bleeding with people on Coumadin, warfarin, or any antiplatelet as people who are not on blood thinners. There's a low risk of that. But there's a risk if you have certain implants, if you have electrical devices, how you receive it, there's a risk, and there's a risk if you use herbal remedies for the reasons that were just mentioned.
And I'm glad he took the acupuncture piece. That was what I was hoping you would do. For the mindfulness piece, the landmark work on this was done by John Kabat-Zinn out of Yale, and his work is readily available online. Just Google mindfulness or John Kabat, it's spelled Kabat-Zinn with 2 N's, I believe. And he's about our age, a little bit older, and so he's very contemporary. He speaks in very plain language, and it's really accessible stuff. I would add, by the way, that Dr. Mackay earlier referenced some deep breathing exercises. And if you all want at the end to save a moment or find me in the back, this is super easy to teach. In fact, I assign this almost like a prescription for my patients to have people, can I tell them just for a second?
Absolutely.
So in essence, the method I use, and mindfulness is sort of a technique built on top of this, is to do, and anyone who's given birth roughly knows this method as well. You breathe deeply in through your nose, exercise the lower lobes of your lungs so that you get a deep breath in to the fullness of your belly, hold it, and then release out through your mouth like you're blowing, bubbles. And I teach everybody the count of 3, 3, 5. So it's in for 3, hold for 3, and out for 5. And I use a visual with my patients so that it sometimes gives people a helpful thing to have an image to focus on while they're learning this technique. So I'll say in for 3, hold for 3, and then out for 5 as you're exhaling long and slow. It's like the brake and the gas in the car. You've got to brake longer to slow the car down, right? So you need to exhale longer to slow your body down. And I have almost all my patients practicing this 3 times a day, working their way up from 5 to 15 minutes at a time. And that way you're evoking something called the relaxation response with the parasympathetic nervous system. Super easy. It's free, it's accessible, you can do it anywhere, and it's a natural way to help get your body's relaxation response up, and then it'll be at the ready instead of like a feather floating down to the ground when you need to be able to call on that relaxation in your body. It's like a stone just plummeting to the bottom of a pool. Your body, the more you practice it, it should have this response at the ready to do. Mindfulness is building upon that kind of intention with awareness of being in the moment. So that's basically the essence of mindfulness. And John Kabat-Zinn's work is helpful. Okay.
Great, thank you so much. So I have a lot of other questions. This is the final one, and if you had ones that we didn't answer, I think the panelists will probably hang out throughout this next 5-10 minute break, if that's okay. I can say that. This goes to Dr. This goes to Dr. Mackay. Marijuana. Thoughts?
Where? So it's true this panel's gone to pot. All right. I'm here all week. Get the meatloaf. Marijuana is something. It really is. And the medicinal potential of marijuana is profound. The problem is the execution of that and identifying the right chemical construct. So marijuana is a mixture of cannabinols, cannabinoids, and flavonoids. I may be betraying some of my past as I explain this. And the flavonoids are in part responsible for the high you get, right? Do you like a really introspective feeling? Do you like to be extroverted? Do you like to get the munchies? Do you not like to get the munchies? Now, marijuana tends to be pretty stable. You don't see too many flip out on marijuana. It can sure happen, right? But that's not true with the synthetic marijuanas, with K2 and spice. So the proportion which bind the CB1, cannabinoid 1 receptor, and the cannabinoid 2 receptor is altered when you start mucking around and doing science with the cannabinoids. And you tend to get too much CB1. CB1 is the one that's primarily in the central nervous system. So CB1 is the one they wanted to use with a medication called rambinate, which is a CB1 antagonist that is supposed to change the way you want to eat. Helps cut down in part on some of the munchies. Changes the endovascular system. The problem is there's a profound mood dysphoria that is associated with it. So it's true, you eat a little bit less and you have endovascular health, but it ruins your mood. CB2 is the one that you guys are interested in, because CB2 is the one that's associated with interleukin 10. CB2 is, and helps that, so it helps switch from the Th17, Th1, Th2 bad immune proliferation to the Th10 Treg good immune proliferation. CB1 is largely responsible for fibrosis. So what we need is not necessarily marijuana, because marijuana will bind that site and trigger fibrosis in some people. The synthetics, that's what they would do. So you want an antagonist, an anti-marijuana to hit that CB1. Now, that's part of what is in marijuana. That's part of the reason it's a balanced thing, is that it has antagonists in it. So part of the cannabinoids are both positive and anti. So they're a mixed agonist. And just like we have pain medicine, buprenorphine is one, it's a mixed agonist. So that would help mitigate against some of the dysphoria that it's caused, the bad feelings in the brain, and it can help block some of the fibrosis that's triggered by CB1 manifestation in the liver. And then the CB2 is easier to get at because that's just an agonist. So marijuana would stimulate that, which can help the anti-inflammatory property. And we already know that it works for inflammatory conditions, right? Marijuana helps dilate the bronchioles in asthma. Asthma is an inflammatory condition. So it has an analgesic property, which is beneficial to people that are hurting. It has a pro-appetite benefit. It actually, to any of you that have neuropathic pain, it works for neuropathic pain. If you have diabetes, I shouldn't be saying this because you guys are going to go out and smoke a doobie. It also tends to be corrective. So chronic marijuana users tend to have a smaller waist circumference and better glycemic control, even though they consume more calories, because it has a corrective effect on the metabolism. Please don't record that. So it's a complicated thing, and there are potentials, and they're isolating the various constituents and trying to reassemble them in a way that you have a CB1 antagonist interfere with the fibrotic problem in the liver, CB2 agonist, so that it generates that transition, that interleukin 10. Please.
If I can just build on what he's saying, a caution on a couple of notes. He mentioned ruining mood. There is risk for mood change for a lot of people with marijuana use, risk of anxiety change. For some people, that's for the better, for some people, for the worse, and cognitive changes as well. And I would caution people who are in liver disease, there can often be cognitive or personality changes, especially with encephalopathy. And that can be hard for caregivers as well. This is just a note of caution together with what Dr. Mackay has said. And there is evidence around nausea and vomiting that people think of this as sort of an antiemetic, meaning helps people with nausea, and for many it does. And yet there's also evidence linking this to some pro-vomiting tendencies for people. So I'm sure Dr. Mackay is very familiar with that.
It is true. It's associated with a headache and a vomiting syndrome with chronic marijuana users.
Well, let's end there, guys. Can we give a round of applause for our panel? Thank you. Thank you guys so much. So let's start with some Q&A. And I think, Dr. DeGroot, you had said you maybe need to ask some questions about how you could find out about research opportunities. How do you go about that? And maybe I can help with that too.
Yeah, I would love for you to help with that. So wherever they come up, I think is the quick answer to that. So the GRACE study would be a good starting point. And if you're local here, asking your provider about any research that they may be aware of, the national websites as well, the National Institutes for Diabetes, Digestive Diseases, and Kidneys posts ongoing research. So your thoughts?
I think that's great, and I think our aspect of social media is really a novel approach that we actually can look at these areas of interest. And again, maybe it's more in a hypothesis-generating kind of fashion, but again, I think we're realizing these are unmeasured gaps in this disease and need more optimal therapy. A question for Dr. Johns. You talked about treating fatigue and cancer, and I think this came in after your slide that you put in, but how successful are you with some of these approaches in application? Can I expect some of these same results?
Well, we don't know for sure how any of these will work in AIH. But what we do know is that cancer-related fatigue is very, very serious, and it's a pervasive symptom that affects almost everyone on treatment. And then even post-treatment, it affects about 30% of people in a fairly severe way. And so because of the strength of the evidence supporting interventions in cancer, we've got to start somewhere in AIH. And so we might want to start with interventions that have worked for other diseases like cancer. And see what's going to to work, but the only way we're going to know is if we do some research where we can do it in a randomized controlled clinical trial so that we can see really what is going to help. But common sense would tell us all that becoming more physically active in a way that's reasonable and that's possible for us is definitely going to be part of the answer for almost everyone, because we all need to move our bodies more, and if we're fatigued, oftentimes we're not moving. So that would be a good place to start, but we have to do the exercise in a safe way and in a way that we're going to keep up with it. We don't want to do it so much, go so deep into it that we just feel like this is not feasible for me. So I'm not sure I totally answered your question, but we've got to start somewhere.
I think that's a good place. Dr. DeGroot, in your opinion, particularly from what you understand with diabetes and depression, could my depression affect my AIH?
Yeah, so one of the things that we've learned in diabetes is that it's a bidirectional relationship between depression and diabetes. So we used to believe that diabetes came first and then depression followed, because diabetes places a lot of demands on patients for self-care. What we've been learning, though, in the past 5 to 7 years is that, in fact, people who have a lifetime history of depression have a 38 to 40% increased risk of developing type 2 diabetes later in life. And what's really interesting about that finding is that that relationship accounts for the additional risk after accounting for other factors like gender, poverty, obesity, and other factors that are common to depression and type 2 diabetes. So we've been learning that there's this bidirectional relationship. The literature that is available for AIH right now suggests that bidirectional relationship is true for AIH as well, although, again, much more needs to be learned. I can add just one other thought that came to me after the last wonderful question about research. For those folks who are here in Indiana, the Clinical Translational Science Institute, or CTSI, has a registry called In Research. And so for folks who are local to Indiana, I would encourage you to get on that registry as well. It will ask you a lot of survey items about who you are and your medical diagnoses. And then that's a pool of people that researchers like myself and Dr. Johns and others will tap into when we have funded studies. So that's another good resource for you.
Great. And Dr. Johns, I had contacted Dr. Johns here a couple months ago about getting some of the resources that she thinks are good resources that are free and may parlay into something that's maybe more monetarily based as far as mindfulness. I'm assuming if it's okay with you, I'll share those on our social media sites. I've given them to a few patients. Can you remind me the name of the gentleman that you had referred to on YouTube if people want to search this?
Mm-hmm. Yes, his name is John Kabat-Zinn, and the spelling for John is Jon, and then Kabat is K-A-B-A-T, and then his last name is Zinn, Z-I-N-N. It's a hyphenated last name. So yeah, just search YouTube for anything that's by John Kabat-Zinn, and that would be a way where you could practice something like what we did today, only he's the expert, and I'm just trying to get there.
Absolutely, no. Dr. DeGroot, can you give us some tips for dealing, this is a little bit open, but dealing for mood changes and or for Dr. John's fatigue during a steroid taper? So in the setting of prednisone, so maybe medication related.
Well, one thing that I would suggest with regard to the fatigue symptom is to have that structured daily schedule, because it's difficult when you're doing that taper. And so I would encourage the structured daily schedule, and also make sure that you're doing everything that you can to maximize the quality of your sleep, such as the standard going to bed time and the standard wake up time. So those would just be a couple of things that you could try, and also paying attention to the emotional symptoms as well.
I think one piece of that is setting realistic expectations for yourself. So one of the things that I really like about what you said, Shelley, is really tuning into ourselves and what effects medications have for you. So what does that look like, and what does the taper look like for you? When we're curious about our bodies and we're looking for these patterns, we tend to set more realistic expectations for ourselves so that we're not kind of caught up in stress cycles of expectations that we're then unable to be able to meet. So kind of understanding that a steroid taper is, you're going to feel different, and that's okay because that's short term. And so being gentle with yourself around that time, I think is important.
That's great advice. I'm just going to end with one question. It's kind of a big one that I'm going to put across all three of us. This is actually more about doctor selection. I think it's a good one for you too, maybe. It's been recommended I identify a primary doctor, like a generalist, given I have AIH. What questions do you recommend I ask or look for in selecting a primary care doctor? And I want to frame this in the setting of also your guys' talks as well, as far as fatigue and depression. And then maybe I can chime in with what I think as a hepatologist.
Sure. Well, I think one of the things we know about doctor-patient communication is that it works when you're comfortable. Right, so finding someone that you feel confident in, so doing a little bit of homework, finding out who that provider is, where they trained, knowing a little bit about yourself and being able to communicate that with your provider can be very helpful. For some patients, they really like their doctor to be the expert. And so they like the flow of information to go from the expert to the patient. For other people, and I would include myself in this, I tend to be more of a collaborator. So there's two experts in the room if I'm the patient. I'm the expert on me, and my doctor is the expert on whatever I'm seeing them for. And so knowing a little bit about how you learn best, knowing what you're looking for in the kind of rapport that you would like to have with your doctor is good homework and good reflection that you can take into that interaction. And then sharing that with your provider. So sharing how you learn best. Maybe that's making sure that things are written down at the end of your appointment, because there's probably a lot of information that's shared during a fairly brief period of time. If your doctor's appointments are like that, they're pretty typical. So I would say that those are the first few ingredients that you'd like to have, at least in terms of building a working relationship with your healthcare provider. What would you say, Sean?
And then a couple of other things that I would add, in addition to the skillful things that Mary said, is first of all, you can always, go and interview, your doctor. Go and have that first appointment. And if that person just really rubs you the wrong way, you don't have to go back. I oftentimes like to give everybody 3 sessions, to see how it goes. And so, after about 3 sessions with one provider, I pretty much know if we're going to be in alignment, with my treatment goals and with our approach to things. The other thing is ask around, because one of the best ways to get names of really skillful providers is to talk with other people who are seeing different providers, to see who gets lots of good word on the street. So those are a couple of things to think about. And then also, you might want to just look at communication style as well. And Mary kind of, talked a bit about this, but if there is a provider that has a very open communication style that you really appreciate, that's going to be better. But if your provider, never maintains any eye contact with you, and you really are somebody who likes that, then, you kind of know that their behavior probably isn't going to change a whole lot. So those would be some of the things that I would look at.
I think that's great advice. My personal opinion, I commonly ask many of my patients about any prior bad encounters, and again, I try to make myself look good by fitting those pieces. But again, this is a team, at least in my office, we do a lot of shared decision making and definitely involve the patient, and education is key as well. But I think it's about managing expectations too, not only for the physician, but as a patient. So as a patient, do you expect the doctor is going to call you? Does the doctor know or that you think he's going to call you? So these are considerations, and I think if you have expectations laid out, at least in the first 1 or 2 visits, and as you develop that relationship, hopefully you don't set yourself up for being unhappy.
I Can I just add one other piece? And this was something that, a reaction that I get from people on a regular basis, you may get this too, Shelley, is that sometimes when we're talking about the psychosocial issues, I think Shelley and I both mentioned that, your doctor may not raise this because there's so much to cover in a short period of time, but that it's important that we're empowering you to raise this with your doctor. And sometimes there can be a response of things like, my doctor doesn't want to hear about this, or my doctor doesn't know that this is, doesn't know what to do with this, or my doctor may not believe in psychosocial aspects of illness. In those, and you may have providers that come across that way, or may even have some of those beliefs. But do know that as a patient, your voice really matters, even if that's for a brief period of time. Your doctor needs to know about you because they're treating you. They also need to know about patient experience. And in this particular disease state, there is not a ton of literature out there yet. And so your personal testimony to your doctor doesn't have to be a long speech. It doesn't have to be, hours and hours. But really sharing that dimension with your doctor helps to educate them. It educates them about you as a person, but it also educates them about what other patients who may have similar medical presentations to yours may be experiencing as well. So you're kind of planting, I like to think about it from a farming perspective, you're planting seeds. So even if your doctor seems a little intractable, every piece of feedback that you provide in a respectful way, of course, in an effective way, can be really helpful for your doctor to be sensitized to these issues so that ultimately they can be helpful to you.
Well, thank you again, Dr. DeGroot and Dr. Johns, and thank you all for being with us today. We'll see you tomorrow. Get some rest. Thank you.